Welcome to the deep dive. Today, we're tackling a really fascinating aspect of how our bodies, how bodies in general maintain balance, metabolic alkalosis.
Right, which is essentially when the body's pH level climbs too high. In the blood, we specifically call that alkalemia.
And it happens because there's either too much bicarbonate, which is alkaline, or maybe a loss of acid?
Exactly. And for this deep dive, we're looking at it, interestingly, through the lens of traditional veterinary medicine.
Okay. So, animal focused.
Well, yes, the source is veterinary, but the core physiological principles, they're fundamental. How pH balance works, how bodies try to correct imbalances, it's broadly relevant. It gives us a great model for understanding these systems.
Makes sense. So our mission today is to kind of unpack the different ways metabolic alkalosis can pop up and look at how the body tries to, compensate.
Yeah, those compensatory mechanisms are key.
Okay, let's dive in then. When we look at lab results, what are the smoking guns, the signs that point straight to metabolic alkalosis?
Well, first off, you'll see an elevated blood pH. That's the main flag.
Higher pH means more alkaline. Got it.
Then you look at the plasma bicarbonate level. In dogs, if it's over, say, 24 milliequivalents per liter,
Okay.
and in cats, over 22. Those are the thresholds we watch.
So specific numbers there.
Right. And we also look at something called base excess. If that's up over 4 millimoles per liter, it's another strong indicator.
Base excess, what does that tell us exactly?
It's a broader measure, really. It looks at the overall balance, considering all the buffering systems, not just bicarbonate.
I see. And you mentioned compensation.
Yes, you'll often see a compensatory increase in the carbon dioxide level in the blood, PCO2. The body's trying to add some acid back into the system to fight the alkalosis.
Right, the body's fighting back. Now, the source material mentions two main ways this whole thing starts. Two pathways.
That's right. It boils down to either gaining bicarbonate or losing acid.
Okay, let's start with gaining bicarbonate. How does that happen?
One common way is something called contraction alkalosis. This happens when there's a deficit of free water.
So like dehydration, if you lose water, the bicarbonate that's already there just gets more concentrated.
Exactly. It's like concentrating juice, like you
Yeah.
said earlier. Simple concentration effect.
Makes intuitive sense. What else leads to bicarbonate gain?
Well, sometimes it's iatrogenic, meaning it's caused by medical treatment, giving alkalinizing stuff like sodium bicarbonate directly,
Okay. Intentional, but maybe too much.
or unintentional overdose, yeah. Then there's the metabolism of certain organic ions, things like lactate, citrate, acetate, even ketones, surprisingly. Your body turns them into bicarbonate.
Interesting. Lactate is usually associated with acidosis, isn't it?
It is in lactic acidosis. But metabolizing lactate can actually produce bicarbonate. Also, low potassium hypokalemia can contribute.
Low potassium raises bicarbonate. How?
It's complex, involves ion shifts and kidney function. We can circle back to that. And finally, the kidneys themselves can generate more bicarbonate through a process called renal ammoniogenesis.
Wow. Okay. So quite a few routes to gain bicarbonate. What about the other side, losing acid?
Acid loss is maybe more obvious sometimes. Think about losing stomach acid.
Like with persistent vomiting.
Exactly. Vomiting, or even things like nasogastric suctioning in a hospital setting. You're just physically removing acid.
Okay. Where else can acid be lost?
The kidneys are another major site. Certain diuretics, specifically loop and thiazide types, can make you lose more acid in your urine.
Diuretics again. They seem involved in a lot of electrolyte stuff.
They really are. Also, certain hormonal issues, like having too much mineralocorticoid, think aldosterone. Those hormones can make the kidneys dump extra acid.
Hormonal links too.
Yep. And even having non-reabsorbable anions in the filtrate can play a role. And maybe counterintuitively, having less of certain weak acids in the blood can raise the pH.
Less acid raises pH. How does that work?
We're talking mainly about low albumin hypoalbuminemia or low phosphate hypophosphatemia. Since they act as weak acids in the blood, having less of them shifts the balance towards alkaline.
So even your protein levels matter for pH. That's quite something.
It really highlights how interconnected everything is.
Okay, so the kidneys. They're usually the cleanup crew for getting rid of excess stuff, right? Why doesn't metabolic alkalosis just get filtered out? Why does it stick around?
That's a really crucial point. Normally, yes, the kidneys are super efficient at excreting extra bicarbonate,
But
that efficiency can be hampered. Several things can get in the way,
like what?
like having a decreased effective circulating volume. It's not just total fluid, but does the body think it has enough blood flow? If not, the kidneys react.
Ah, the body's perception matters.
Definitely. Also low potassium, which we mentioned,
Mm-hmm.
and low chloride levels, hypochloremia, and
Mm.
high levels of that hormone aldosterone we talked about. All these can make it hard for the kidneys to ditch the extra bicarbonate.
So the alkalosis persists because the kidneys can't excrete the bicarbonate, maybe because alkali is still being added, or is it something about sodium and chloride?
Yes, exactly. Or because the kidneys are trying desperately to hold on to sodium, maybe because volume is low, but chloride isn't available to come along with it, so they grab bicarbonate instead.
Which just keeps the alkalosis going.
Precisely.
You mentioned hypochloremic alkalosis specifically. Low chloride. Can we look closer at that? It sounds important.
It is. Hypochloremic alkalosis basically stems from losing fluids that are rich in both chloride and hydrogen ions.
Like stomach fluid again?
Stomach fluid is a big one, yeah.
Yeah.
Or losses through the kidneys, like with those diuretics. You lose the chloride, you lose the acid, and bicarbonate concentration goes up relatively.
Okay.
And then, like we just touched on, if the body also thinks it's low on volume because of those fluid losses, the kidneys go into sodium saving mode.
Right.
But because chloride is low, they reabsorb sodium paired with bicarbonate instead. So you lose chloride, and the body's attempt to save sodium actually makes the alkalosis worse.
Wow, it really does perpetuate itself. And I see it's split into chloride responsive and chloride resistant types. What's the difference?
Good question. Chloride responsive is usually what you see with those fluid losses, GI or renal. The body is typically volume depleted, chloride levels are low in the blood, and crucially, chloride levels in the urine are very low, usually less than 10 millieql.
And responsive means?
It means if you give fluids containing chloride, it helps fix the problem.
Okay. So chloride resistant.
That's often linked to that mineralocorticoid excess, too much aldosterone, for example. Here, the body might actually seem volume expanded, not depleted. And the key difference, urinary chloride is high, usually over 20 of LEQL.
And giving chloride won't fix it.
Nope. You have to address the underlying hormonal issue. Giving chloride doesn't really touch it.
That's a critical distinction for treatment, I imagine.
Absolutely.
You also flagged other electrolytes. We touched on potassium, but can we go deeper? How does low potassium really drive this?
Okay, hypokalemia. It works in a few ways. One, when potassium is low outside cells, hydrogen ions tend to move into cells to try and balance the charge.
Leaving fewer hydrogen ions, more alkaline outside.
Exactly. More bicarbonate left behind in the blood. Two, low potassium stimulates a specific pump in the kidney tubules, the H plus K plus ATPase. This pump basically swaps hydrogen ions out into the urine for potassium ions in, so you lose more acid.
Ah, so direct acid loss promoted by low potassium.
Right. Third, low potassium ramps up ammonia production by the kidneys, which ultimately helps generate more bicarbonate.
Okay.
Fourth, it can mess with how chloride is reabsorbed. And fifth, it can even reduce the kidney's overall filtering ability, the GFR, making it harder to clear that excess bicarbonate.
Man, potassium really is involved everywhere here.
It's a major player in acid-base balance, for sure.
Okay, what about albumin? You said low albumin, hypoalbuminemia can cause alkalosis. That still seems odd for a protein.
It does seem odd, but albumin is the main protein in plasma, and it actually behaves like a weak acid. It has negative charges that can accept hydrogen ions.
So it buffers the blood, essentially.
Kinda, yeah. So if you have less albumin, you have less of this weak acid around.
Right.
The overall balance shifts slightly more alkaline.
And there are actual numbers for this.
Yeah, the source gives estimates. Like in cats, for every 1 GDL drop in albumin, the pH might go up by about 0.093. In dogs, it's a bit less, maybe 0.047.
That's measurable. It really shows how things we don't normally think of as acids or bases still contribute to the overall pH picture.
Exactly. It's all part of that complex buffering system.
So the body finds itself in this alkaline state. Does it just sit there?
Yeah.
Or does it try to fight back? We mentioned the CO2 thing.
Oh, it definitely fights back. The body is always aiming for equilibrium, for homeostasis.
So how does it compensate for metabolic alkalosis specifically?
The primary way is through the respiratory system. The body senses the low hydrogen ion concentration, the high pH.
Okay.
And the response is to slow down breathing, both rate and depth. It's called hypoventilation.
Breathing less. Why?
To hold on to carbon dioxide. CO2 dissolves in blood to form carbonic acid. So by retaining CO2, you're increasing the acid level in the blood.
Trying to counteract the excess bicarbonate? Clever.
It is, using an acid to fight a base.
Is there a predictable relationship? Like, how much does breathing change?
There's a general rule of thumb, at least in dogs. For every 1 EQL rise in bicarbonate, the PCO2 tends to go up by about 0.7 millimole Hg.
As a direct compensation.
Right. The data for cats is a bit more limited, but it seems to follow a similar pattern. Respiratory compensation happens.
Okay, we've covered the how and the why and the body's reaction. What might you actually see? What are the signs or symptoms if an animal, or presumably a person, has this?
Well, the signs can be really varied, and often they tie back to whatever caused the alkalosis in the first place.
Makes sense.
So the history is important. Did they use those diuretics? Have they been vomiting a lot? Those are big clues.
Right. In on examination.
You might see signs of the underlying disease, whatever that is, or signs specifically related to potassium depletion, things like muscle weakness, maybe heart rhythm issues, sometimes gut problems.
Mm-hmm.
Alkalosis can also sometimes lower the ionized calcium level in the blood, which can cause muscle twitching.
Twitching. Okay.
And if there's been fluid loss, you might see signs of dehydration. It's rare, but severe cases could potentially lead to neurological signs like more intense muscle tremors or even seizures.
So that feeling rundown after being sick could actually have this electrolyte imbalance underneath.
It absolutely could, yeah. There can be more going on than just feeling poorly.
Can we group the causes? It seems like a lot of different things lead here.
Yeah, we can categorize them, drawing from the source. It helps make sense of it.
Okay.
We already talked about chloride-responsive alkalosis.
Yeah.
That's mostly about losing those chloride-rich fluids.
Vomiting, diuretics.
Vomiting, nasogastric suctioning, those loop or thiazide diuretics, yeah. Also, sometimes if you rapidly correct chronic respiratory acidosis, you can overshoot into metabolic alkalosis.
Interesting. Okay, so that's chloride responsive resistant.
Chloride-resistant causes are often those hormonal ones. Hyperagenocorticism, Cushing's disease, or primary hyperaldosteronism, conditions with mineralocorticoid.
Okay. Other categories?
Then there's just taking in too much alkali, like orally ingesting sodium bicarbonate.
Baking soda?
Yeah, or other sodium salts of organic anions like lactate or acetate. Some medications like cation exchange resins can also do it.
Okay.
Hypoalbuminemia is another category, low albumin from things like liver disease or losing protein through the kidneys or gut.
Right, the weak acid effect.
Exactly.
Yeah.
Then there's free water deficit, not just simple dehydration, but conditions causing massive water loss like diabetes insipidus, or sometimes after a urinary obstruction is relieved.
First obstruction, diuresis, yeah.
Or even just severe water deprivation. And finally, hypokalemia itself can be considered a cause, although it's often intertwined with other causes too.
Okay, that helps organize it. So if you suspect this, what are the key lab tests again, besides the blood gas?
Well, the blood gas is really central because remember, high bicarbonate and low chloride can also show up as compensation for chronic respiratory acidosis.
Right, where the main problem is high CO2, low pH.
Exactly. So you need the full picture, pH, PCO2, and bicarbonate from the blood gas to know if it's metabolic alkalosis or something else.
And you have to be careful with the sample handling too, right?
Oh, absolutely. Too much heparin anticoagulant in the syringe can throw off results. Letting the sample sit too long before analysis or exposing it to air that lets CO2 escape and falsely raises the pH.
Good points. Venous versus arterial matters too.
It can, yeah. Arterial is the gold standard for blood gases, but venous can give useful info. You just interpret it slightly differently, especially the PCO2.
Okay, so assuming a good sample and blood gas analysis, what else in the standard blood work points towards metabolic alkalosis?
On a regular chemistry panel, you'll usually see high total CO2, or TCO2, which is mostly bicarbonate.
Okay.
You might see low ionized calcium, as we mentioned. Electrolytes can be all over the place depending on the cause, but low chloride hypochloremia is really common with vomiting or diuretics.
Makes sense.
If you see high sodium but normal chloride, that might make you think more about chloride-resistant causes or maybe alkali ingestion. And low albumin, of course, points towards hypoalbuminemic alkalosis.
And urine chloride helps differentiate responsive versus resistant.
Hugely helpful.
Yeah.
Low urine chloride suggests responsive, high suggests resistant.
And back to the blood gas, you said high bicarb, high PCO2 from compensation, high pH, and high base excess.
Right. And the source notes that base excess is often considered a more reliable indicator of the purely metabolic part of the disturbance than bicarbonate alone, because bicarbonate is also influenced by respiratory changes.
Okay, that's a subtle but important point. So we've got the diagnosis. How do we treat it?
Number one priority always is treat the underlying cause. Whatever started this cascade, you have to address that.
Stop the diuretics, treat the vomiting, manage the heartburn issue.
Exactly. While really severe alkalemia isn't super common, it can be dangerous, especially, say, in a patient with chronic lung disease who then starts vomiting or gets put on diuretics. That's a risky combo,
So, stopping any offending drugs is step one.
definitely. Then the strategy splits based on whether it's chloride responsive or resistant.
Okay, how do you approach chloride responsive?
Fluid therapy is key, specifically fluids containing chloride. If the patient is dehydrated, you'd typically use an intravenous balanced isotonic solution like normal saline or something similar.
And if potassium is also low,
Good point. If they're hypokalemic, you'd add potassium chloride to those IV fluids. Give back the chloride and the potassium.
okay. What about chloride resistant? Giving chloride doesn't work there, you said.
Right. For chloride-resistant alkalosis, fixing it really hinges on treating the underlying disease, managing the Cushing's or the hyperaldosteronism.
So, specific treatments for those conditions.
Yes. Although, if hypokalemia is also present in these resistant cases, giving potassium chloride can still help correct the alkalosis, even if it doesn't fix the root hormonal cause.
Interesting. And general supportive care.
Oh yeah, always important. Making sure they're hydrated, getting adequate nutrition, just general good nursing care helps everything.
Are there specific medications used to treat the alkalosis itself beyond fluids?
Sometimes. For chloride-responsive cases where maybe the patient has edema, fluid overload, you might use oral chloride salts that don't contain sodium.
To give chloride without adding volume?
Precisely. If you need diuresis but want to help the alkalosis, you might consider carbonic anhydrase inhibitors or potassium-sparing diuretics, as they tend to promote bicarbonate excretion or reduce acid loss compared to loop thiazide diuretics.
Okay. What about ongoing stomach acid loss?
You might use H2 blockers or other anti-ulcer meds plus anti-nausea drugs to reduce those losses.
And for the hypoalbumemic type?
Treatment focuses on the cause of the low albumin nutritional support, maybe specific treatments for kidney or gut disease. In really severe cases, albumin transfusions might be considered, but that's usually a temporary fix.
Got it. Anything to specifically avoid?
Yes. Don't use chloride-free IV fluids, obviously,
Yeah.
and don't give potassium salts without chloride. If you're trying to fix a hypochloremic alkalosis, you need the chloride. And be careful with certain diuretics if the patient is already volume depleted. You could make things worse.
Makes sense. Once treatment starts, how closely do you monitor?
You need to follow up with repeat acid-base measurements. How often depends entirely on the case, how severe it was, what the underlying cause is, how they're responding. It's very individualized.
And potential complications to watch out for?
The main ones mentioned are hypokalemia, which can be both cause and effect, as we've seen, and those rarer neurological signs if the alkalosis or associated electrolyte shifts become severe.
Well, this has definitely been a thorough exploration of metabolic alkalosis. Quite complex.
It really is. And I think the key takeaway is that it's not just a high pH number. It's a sign of an underlying disruption in a very complex regulatory system.
Yeah, involving kidneys, lungs, hormones, electrolyte.
Exactly. And understanding why the underlying cause and the specific mechanisms at play is absolutely critical for managing it effectively.
And hopefully for you listening, this deep dive gives a solid framework for understanding just how interconnected these body systems are when it comes to maintaining that delicate pH balance.
It really does.
Yeah.
And maybe it leaves you with something to think about.
Yeah.
Consider how something seemingly simple, like taking a common water pill or having a bad bout of vomiting,
Yeah.
can set off this whole cascade of physiological changes. The body has these incredibly elegant ways of trying to maintain balance, even if they sometimes get overwhelmed. It makes you wonder what other seemingly minor imbalances might be having significant ripple effects inside us.
That is definitely something to ponder. A good place to leave it for today.